Today we will talk about some cardiovascular diseases. Certainly, we can't get to all of them in a brief meeting like this one, but we'll talk about some points that should be of interest to everybody in attendance. Now, uh, we're going to get started just with a brief introduction, and then we'll move on to our first question. Those of you that have not met me in previous sessions, I'm Tarman Aziz. I'm an internal medicine physician by training, and I also have a background in CDI operations and hospital revenue cycle consulting, as well as quality consulting work. I've held roles in physician champion, as well as appeal letter author, and directed CDI programs. It's my pleasure to operate CDIQ with our COO, Anna Rosanowski, who is our driver of all business development items and all new product development as well. And Anna guides a team that manages our day-to-day business development through social media, sales, and marketing. And we have strategic channel partners as well that we work with. Uh, Today, we're going to start out with the first question. And what I'm looking for in these sessions, ideally, is not for me to simply put up a question and then reveal the answer and move on, but rather that we simulate how our classes are run in preparing you for the CCDS exam. And quite specifically, how that works is we analyze the right answers as well as all of the incorrect choices for a given test question, a practice question. So I sure hope that you will feel the confidence. I see some familiar names on today's list of attendees. Feel comfortable even if you're not coming on the camera, if you don't mind taking the microphone off of mute and letting us know your thoughts on a question so I can then ask additional questions related to them. It would be very helpful and make the session quite a bit more productive. So please participate to the degree that you're willing to. All right, so let's get started right away with our first question. I'm going to give everybody about a minute to read this one, and then we'll get into analyzing and discussing it. As you start looking at the provider documentation, the narrative of the case scenario, and the answer choices, if you feel you know which answer is correct, feel free to share with us as soon as you feel you know the answer. You're also welcome to text via the chat box your answer to the group. I'll be looking for volunteers to maybe read this question out for us and tell us what resonated with you to help you get to the answer for this question. Thank you, Kaylee, for your response. What do you like about the choice that you've selected? Can you share more with us, either by way of microphone or further chat commentary?
Sure. I picked A because the person has diastolic heart failure uh, in their history. Their ejection fraction's much lower now, so maybe it's combined. And everyone has to take what I say with a grain of salt, because I'm only 6 months into my CDI journey, so I'm learning a lot as I go along.
Hey, no worries at all. I appreciate the input on the question, and I appreciate your thought process on the question. We do see here that the patient has a known history of diastolic heart failure, and we see that the documentation uh, includes, or not the document, we're not up to the documentation just yet, but the ejection fraction may not be consistent with that. We see less than 50%, in fact, approaching 40%. So it sure looks like the EF dropped off considerably from whenever this patient was deemed to have diastolic heart failure. Reasonable thought. Anything wrong with choice A? Yeah, we have some good signs of acuity here as well. Thank you, Michelle, for your comments as well. You like the answer choice, and the pulmonary edema um, could be due to any number of types of heart failure. Um, so it's certainly helpful for the acuity of the condition if it's proven to be uh, truly acute heart failure, which it sure seems like it. We have that documentation, heart failure exacerbation, and we even see explicitly stated acute on chronic heart failure with a side commentary about the CKD stage worsening. So, um, what might still be a problem with choice A? And is there another choice that could answer this question just as well as choice A? And if you'd like to talk about why you don't enjoy choice C or D as potential answer choices for this item, do feel free to say so as well. How do we rule out C and D? Neither of those is the answer. So it's either A or B. I won't share which it is yet. I hear somebody talking very faintly in the background. We don't hear you if you're trying to share with us.
This is Haley. Can you hear me?
We can just about hear you now. Yes, thank you,
Oh,
Kaylee.
string. For C, isn't the relationship assumed between hypertension, heart failure, and CKD for the codes? You wouldn't necessarily need a query for that relationship.
Very good. Yeah, that's a presumed relationship between CKD, hypertension, and heart failure, unless circumstances indicate something to the contrary, to where we should not presume that relationship, which comes up from time to time. Good. Um, so that's why C is no good. What about choice D? Clarify any link between the advanced CKD stage and the pulmonary edema for this admission. Any thoughts there? Could advancing CKD stage cause more flares of acute on chronic heart failure? Why or why not? Well, we know, for example, that CKD patients may become fluid overloaded, particularly when they are uh, dealing with some acute kidney injury superimposed on their CKD stage 4. And with an acute flare of CHF, perhaps that forward momentum of blood towards the kidneys is somewhat compromised. So a potential flare of AKI on CKD stage 4 wouldn't be out of the question. But what are we doing to start playing with choice D? That's a big no-no in CDI and therefore makes for an incorrect choice on the CCDS exam. In this case, we are We're being extremely leading, Michelle. Very good. Alicia, yes, you're correct as well. We're being extremely leading. Alicia, I saw your comment about are they treating acute or chronic. Uh, we're also interested in choice B and what type of heart failure is being treated. So good, but leading is correct for D. We're not meant to use our own medical insights from whatever profession we come from into CDI to add that knowledge into the query process and interrogate providers about additional clinical conclusions that one might make from the indicators. We only care if the documentation reflects the true, apparent patient presentation, and will that documentation then line up with the appropriate ICD-10 code. All right, so in this case, looking back at choice A and B, could one of them be more leading than the other, and why? Let's pitch a case between A and B now. Very good, Alicia. You'd need to add the indicators into your query and give them multiple choice options. Michelle, you feel that A is more leading, and why is that? Ejection fraction for this admission is 45%. Please clarify if diastolic heart failure is now combined systolic and diastolic heart failure. I agree
It's
with
almost,
you, Michelle. Go ahead, whoever's speaking.
I was going to say it's almost like telling the provider to choose that option as a diagnosis.
Yes, that makes it leading. You're framing the question in a way that sort of leads the provider towards a desired answer, if you will. G is this combined. Nice thought, but we're not meant to do that. And how are we even posing that question? That's no problem, Michelle. You don't have to speak on mic. We appreciate the text comments as well, the chat box comments. So, all right, we have the ability to ask question A, perhaps, because we have a skill set, but we've actually gone in by writing choice A, read the past medical history or the known current chronic conditions, diastolic heart failure included. We've then looked at the latest ejection fraction, and we have made our own conclusion regarding what we think that means clinically. So it's no different in the end to choice D in what we're doing on the record here. All right. Accordingly, if we ask choice B, do we get the same information? Please clarify the current type of heart failure being treated. We'll also be told, because we're going to give her Alicia's point, good point, we're going to give all of the indicators that are pertinent here. We are then going to ask, please clarify the current type of heart failure being treated, including systolic, diastolic, combined systolic and diastolic, other, not that there's many other types we can talk about. I mean, there are subtypes, but those are the main ones we care about, but we want that other answer choice in the query options too. And then finally, unknown, unable to determine. So yes, B is the correct answer in this case. We cannot pick up the acuity of heart failure unless we know the type as well. That's not true for acute respiratory failure, for example. To contrast, acute respiratory failure, you will have an impact with the acuity for an MCC chart impact, whether you bother to specify hypoxic, hypercapnic, or both. However, it's nice if you can specify hypoxic, hypercapnic, or both for the type of acute respiratory failure, but it's not a mandate to capture that acuity for that MCC. By contrast, here with acute on chronic CHF as documented, we can't do anything with that in terms of picking up acuity until you give us the type and the acuity at the same time in the same note, ideally, same line item, optimally, we cannot assign that acuity. So CHF type is critical here, but A asks it in a leading fashion. C is, as correctly stated in the discussion here, a presumed relationship. And anyway, even if you did get that clarified by query, to be extra, extra, extra sure will be frivolous, unnecessary, and contributes to query fatigue. But let's say you did it anyway. You would not have solved the issue at hand by getting that relationship established. All you would have done is either established possibly a different PDX in the form of I1 3.0 for the combined influences of those those diagnostic relationships, and you would have your acuity code, possibly, if you get it by the proper query, as secondary. All right, so make sure you know the sequencing rules. A related question to this might be what code is actually going to be used for the PDX. It's not going to be an I50 code for acute on chronic combined CHF. It's going to be probably I130 for that presumed relationship, with the I50 code as a secondary code, but still drives the DRG assignment. All right, and the A and D are decidedly leading in nature. So thank you for the discussion around that first item. Let's go ahead and move on to the second one. Good, I see responses from Alicia as well as Kaylee. Anybody else want to add in their opinion before we start discussing? Give a little more time for reading. Very good. Those of you that are sending in your answers by way of chat are all correct. Would anyone like to tell us why choice D, as in David, the shock etiology, is the correct answer here? How does it
Because
match with what's being asked?
you can treat with pressors with heart failure, but when it goes into shock, that makes it more of a more prominent, maybe.
Okay, certainly the presence of IV vasopressors suggests that we have much more worsening hemodynamic status, and it can clinically validate various types of shock. What is the connection between choice D and what's specifically asked in this question? How would you translate this question, the final sentence, if you had to translate it into a one-line statement or a shorter statement? What do we mean by the secondary diagnosis? What's the secondary diagnosis and what's the principal diagnosis likely to be from the information we have? I would say it looks like we have some acute form of heart failure, probably acute on chronic systolic heart failure as a principal diagnosis. So that means our secondary diagnosis must be shock. So the question is asking about shock, and it's asking what detail about shock for this particular scenario will make that secondary diagnosis the most impactful to severity metrics. So how can we justify D from that type of perspective? What type of metric impact do we have on the record right now regarding shock based on how the quoted provider documentation reads without any query clarification being sent? What code will you select? And what will the impact be on the record? Remember, some secondaries are CCs, some are MCCs, some are HCCs. Some are none of those, but they still affect various risk adjustment outcomes. Okay, so let's take a look at the answer together. You're all right regarding the answer. D is the correct answer, but let's talk about why. So this patient, we want to know what type of shock do they have because we're seeking an MCC impact rather than a CC impact. It's certainly compliant to do so because we have every reason here to believe a specific type of shock is present. What would we guess is the specific type of shock, despite the omission from the documentation? What would we guess is the specific type of shock present in this particular patient? Yeah, it sure sounds like cardiogenic shock to me too. Alicia, Kaylee, agree with you. So do you get a CC or an MCC out of cardiogenic shock? MCC is correct, Alicia. Good. What about the shock that's been documented here? What is the impact on the record and why? What type of shock will you code from the provider documentation? Yes, very good. It's an unspecified shock, which holds only a CC impact. So per the commentary at the bottom of the paragraph of the question stem, the specificity of shock gives us an MCC rather than just a CC for unspecified shock. Big difference depending on the PDX. The DRG assignment with and without MCC, if it's to be the only MCC on the case, can be quite significant. Now we know these patients probably will have more than one MCC given the profound nature of their illness, but still important that that first one is identified properly. And as they stack, MCCs and CCs will, of course, impact on SOI and ROM, severity of illness, and risk of mortality as well. Now, there's a couple of things to mention about the other choices. Hopefully, most of you ruled out choice C right away because while we want that link between flash pulmonary edema, a clinical turn of phrase, and the notion of an acute exacerbation of chronic systolic heart failure, all we're doing there is tightening up what PDX we want to assign to the case. We don't want to leave it in an unspecified type of acuity level, right? So we don't get acuity and we don't get type either from the provider documentation. But the question asks about the likely secondary diagnosis here, shock. So we don't care about a choice that's going to affect PDX specificity, at least not in the first instance. What about choice B, the type of vasopressor being used, as well as the drip rate and the target MAP, mean arterial pressure? Well, those are great for clinically validating a particular type of shock once you have it on the record. But until you get a type of shock on the record, you could tell me all day, patient has shock and they're now on dobutamine and they're on dobutamine at this drip rate for a target map of 65 or 70 millimeters of mercury, you've not actually defined any specific form of shock there. You've given a good clinical validation for cardiogenic shock, perhaps with dobutamine use, or perhaps for other types of shock, you may use norepinephrine to achieve, vasoconstriction and quickly correct other mechanisms. You may use both, depending on the patient and the timing and the circumstances. But the point is, no named vasopressor and no particular drip rate and target hemodynamic parameter actually defines the shock. The provider has to come out and call it a particular type of shock. That's the point of this question. Let's look at some related concepts here before we move away from question 2. So the etiology of shock is needed for that full patient severity, whether it's septic or cardiogenic or hypovolemic. These are MCC diagnoses, and we want to capture that because it's appropriate. When we can specify the mechanism, it also specifies how seriously ill the patient is. If you are curious to know, for all of the inpatient admissions that do feature shock, statistically speaking, almost 2/3 of them are septic shock. We didn't have indicators of sepsis in this last question. It was more leaning towards a cardiogenic shock, which you can see both cardiogenic and hypovolemic shock both represent about 15% each of that volume of inpatient admissions featuring shock. Anaphylactic and obstructive shock round out our list, clearly a lot less. So good to know the relative proportions approximately of shock that appears in inpatient records to give you an idea of the context and the frequency with which these types of shock might appear. Now, also keep in mind, there is no specific millimeter of mercury mean arterial pressure that you can be asked about on the CCDS to say this absolutely guarantees that we have shock or we don't, simply because the provider is titrating up to a particular mean pressure. Yes, many facilities say less than 70 millimeters of mercury mean arterial pressure can represent shock. Some say less than 65. There's other published literature that have different numbers than either of those. So the key to remember for CCDS exam prep is that local facility guidelines will always prevail when it comes to deciding what the appropriate parameter is around which you then query or don't query or seek further clinical validation. So keep that piece in mind as well. Okay. Also, sometimes you'll get questions about shock in which obviously not for this question, but related questions, where some of the answer choices include provider documentation, which is faulty because the documentation does not align with any ICD-10 code for shock, not even for unspecified shock. And you do see sometimes providers being a little bit tentative and reluctant even at times to document shock. So we see here refractory hypotension or hypotension refractory to fluid bolus. Or you may see some of these other terms, cardiovascular collapse and relative or iatrogenic hypotension. These are not euphemisms for shock. They shouldn't be used as substitutes for shock. And no matter how much you dress it up, refractory hypotension is evidenced by non-responsiveness to several IV fluid boluses and a reasonably fast drip rate of ongoing IV fluids. We still see such and such blood pressure. Nice description. You didn't tell us shock, even if you mentioned in the mix, and we had to add vasopressors, and they were these specific vasopressors. None of that extra clinically validating and valuable, in some ways, information substitutes for the failure to use the word shock or to specify the type of shock as mentioned before. The final piece to keep in mind for the CCDS exam and how you might be tested is to consider post-operative shock. Sometimes shock is a result of a surgical complication. And there it really matters, was that complication an expected outcome because the patient had a pre-existing pathophysiology that perhaps lent itself to that outcome postoperatively? Or is this a true surgical complication? Was there something that went awry with the anesthesia management or an inadvertently nicked blood vessel that decided to bleed quite a bit and more volume was lost than anticipated? So providers, while they may be reluctant to say so, really must elaborate by a operative note addendum, composition, or other ways via query to really clarify if that shock seems to have manifested. What were some of the details intraoperatively that may have either led that to be an expected outcome or an unexpected complication? And be aware that if providers don't write that, and suddenly you look at the medication administration record and you see the use of inotropic agents and vasopressors right after a surgery, that can kind of speak for itself as a possible complication and trigger those queries unless it's otherwise stated. So these are the ways in which shock can appear on the CCDS exam, and also, as you can see, in your daily CDI workflow as well, to drive the chart review and query process. Some postoperative shock cases even tie into patient safety indicators. So we may be more on the alert after learning that shock is postoperative to see if the patient in fact passes away as a result of poor organ perfusion, death rate among surgical inpatients with serious treatable conditions, complications. We see PSIs 9 and 10, post-op hemorrhage or hematoma rate if it's proven to be due to a bleed after a surgery that the patient is in this state, then we would want to know that for potentially impacting PSI reporting, or some cases of shock might lead to post-op AKI when the shock is post-op. And if there's dialysis required, then we may have a PSI impact. So a lot to think about here when it comes to shock as an entity. Let's move on then. Unless there are any questions, I'm happy to take them. On item number 2, we can move on to question 3. Okay, starting to see some answers appear. Alicia, thank you for your input. Can you tell us why you like choice B?
Because he says that the ST elevations go away after admission.
Okay,
But
so good that you saw that. And is there anything in between an ST elevation MI and demand ischemia?
I can't remember that.
We may just have a non-ST elevation MI. What do you think about demand ischemia and the troponin level? Troponin levels are generally what with demand ischemia in terms of percentile elevation? So to define the MI, you need serially elevated troponin values, typically ever increasing in the first instance rather than a flat elevation like you might see in severe CKD or something like that. And one of those values should creep over the 99th percentile to be truly deemed an MI. We want at least one value higher than that in the normal distribution, greater than the 99th percentile troponin. What's the other component for defining an MI? It's some tangible evidence of ischemia, such as symptomatic presentation that we saw here, chest pain, unrelenting substernal. We saw diaphoresis or some EKG changes. The patient also had EKG changes. Okay, so we clearly have defined an MI here. With demand ischemia, the troponin does not exceed this 99th percentile of the normal distribution. So the provider documentation in this question is faulty. It's problematic for coding, doesn't tell us proper things about risk adjustment and patient resource utilization or any of those things. But one thing we know is if the serial troponin values are beyond the 99th percentile in the setting of clear signs of ischemia, this person has likely had a true myocardial infarction. So it argues against choice B in this case. What else might be considered then to get to the right answer between A, C, and D?
I would say the patient, they had stents placed. So that leads me to believe that there was some sort of thrombosis or something going on in the coronary arteries as opposed to just ischemia.
Very nice, nicely said. So because the patient had percutaneous coronary intervention and they received a stent placement
And also
to three coronaries, in fact.
Mhm.
Go ahead, please. The other
And
comment?
also the fibrolytic therapy, which is breaking up the clot. And
Yeah,
then the stent.
good. Yes, we don't roll out TPA, tissue plasminogen activator, or fibrinolytics typically for anything less than a convincing STEMI most of the time, right? That's when we'll get excited to use those in the first period of the admission, if possible. So the question is, does it matter which specific three arteries receive stents? Does it matter to delineate between a type 1 and type 2 MI the most? Or does it matter when they gave the CPA? Which of
The
those
timing
is critical for reimbursement? The timing is very important for clinical management of the illness. In fact, what happened here? This patient has got ST elevation initially, but later on, just before admission, we don't see those ST elevations anymore, which means the clot busting drugs apparently were doing something of value, perhaps. But the timing of fibrinolytic therapy, does that help us delineate what's going on with this provider documentation of a type 2 NSTEMI? What is a type 2 NSTEMI? Can we even code something like that? What is a type 2 MI and what is a type 1 MI? And do we need to clarify it like choice C would suggest? Or does it matter more which of the three coronary arteries received the stent when it comes down to reimbursement? We can
So
reveal
I'm
the.
reading
Oh, so go ahead.
reading that the NSTEMI is oxygenation and the plaque is STEMI. Am I thinking correct?
Well, you're thinking correctly regarding type 1 versus type 2 MI. Type 1 MI is usually caused by uh, occlusion by a cholesterol atherosclerotic plaque. versus type 2 MI caused by oxygen supply demand mismatch. So you've correctly described the difference between type 1 and type 2 MI. The question is, what do we do with type 2 NSTEMI? Where do the STEMIs and NSTEMIs belong, with type 1 or type 2? The language of ST versus non-ST elevation MI belongs with the type 1 myocardial infarction. So a type 2 NSTEMI is very confusing. It's hard to know if the provider means we might have a type 2 MI, or we might have an NSTEMI due to a legitimate cholesterol plaque issue, or a spontaneous thrombosis issue, or embolism, or what have you. So we need to clarify type 1 versus type 2 MI here in order to understand what the patient has. We can't code something from a type 2 NSTEMI with any degree of accuracy or specificity. The timing of the fibrinolytic therapy does not address the issue, but it's a great clinical validation piece for the STEMI, which it certainly appears the patient had. They had initial ST elevations. Doesn't mean that they went, just because they went away after TPA was administered, doesn't take away from coding a STEMI for this patient. So great to know that timing kind of helps to validate that's what the providers were thinking. As far as the demand ischemia, we've mentioned the elevation in troponin is insufficient. And what about choice A? Well, since this question asks about accurate reimbursement, and this is a surgically driven DRG assignment, we'd have to know something about how DRGs are assigned when it comes to PCI cases like this one. And they're assigned based on whether you had 4+ coronary stented or less than 4 when it comes to the number of stents. So that's much more important than wondering which part of the heart was affected. Okay, so just in summary, type 1, coronary thrombosis from atherosclerotic plaque rupture or spontaneous thrombosis at the site. This can include STEMIs and NSTEMIs, and we want that one value at least above the 99th percentile. Usually a couple are. Type 2 AMI, oxygen supply demand mismatch, specific situations. What might provoke it? Profound anemia with compensatory tachycardia, or the tachyarrhythmias, sepsis, shock, hypertensive emergency. There's any number of reasons we may request more oxygen than available for our heart's liking. And we expect to still see with a type 2 AMI that rise and fall. So type 2 NSTEMI, we really don't know what we're dealing with there, because we don't think about atherosclerosis when it comes to type 2 AMI. Also be aware that none of the 5 bulleted points at the top there would ever substitute for acute myocardial infarction. Unstable angina and demand ischemia make enough sense, but acute coronary syndrome is one of the provider's favorites to document, and they feel that it should be equivalent to an acute myocardial infarction, only because they may not be scholars of the coding language. Most of them don't know coding language, and they don't realize necessarily that ACS is not a substitute or equivalent term to acute MI. Hypertroponinemia is simply a lab finding of a high troponin level for which there is no explanation, but we have a clinical scenario with a very likely explanation. So it's not, when you suspect an acute MI, hypertroponinemia is not a substitute word either, nor is acute myocardial injury. If you drop down there, you'll see that that's the elevated troponin, but none of the ischemic symptoms that are typically seen, or EKG changes, or CTA, CT angiograms of the coronaries will all be perfectly normal. Patient will be normal in presentation. No signs or symptoms, no EKG changes, but there's that high troponin. So something has injured the myocardium, but it's not an MI per se. So keep those definitions in mind as you prepare for the CCDS. You need to be very specific in your language, and you need to be very specific in your messaging to yourself as you eliminate answer choices. Just to be complete here, you can see the DRG assignment for percutaneous cardiovascular procedures that feature an intraluminal device. So it's you either have an MCC or you have 4+ arteries, or you don't have 4+ arteries stented. And if you don't have that MCC as well, you're back down to a lower uh, less resource intensive, shorter length of stay type of DRG. Also, keep in mind when there's no intervention and you're dealing just with medical cases of AMI, it matters for the DRG assignment whether the patient was discharged alive or if they were not discharged alive. And it also matters when patients get cath and other procedures done for circulatory disorders when there is no AMI. So that again influences which MSDRG you'll assign. It's important to become familiar with the MSDRG assignment for cardiovascular cases and the associated coding, because on exam day, you may not have the wherewithal or the time to flip through all those pages of the DRG expert efficiently and start figuring out which DRG we're talking about. You need to learn the high yield ones in advance of the exam so that you're not having to look each and every one of them up. They generally don't ask about esoteric DRGs. When it comes to the CCDS exam, you're rewarded for your years in with the industry, with your years in, and you're typically rewarded for knowing commonplace, commonly encountered DRGs. Okay, let's look at another question, please. Great that you shared that with us, Michelle. It is hard to know how long that DVT has been there. Alicia, you like D, and you in fact have the correct answer there in choice D. Kaylee, you as well. So can you share with us, either of you, why you like D?
It says she has pulmonary hypertension, but it doesn't say that she has CAD or anything like that. So it could be acute or chronic pulmonary embolism.
Very good.
Am I leaning right?
You're leaning right. Very good. And you would never code pulmonary embolism as acute or acute on chronic just because the patient's in the ICU and they have a very high D dimer. Those are all nice, again, validating concepts, but they don't define an acute PE. So good job. D is correct. Pulmonary embolism. It's all we got from the provider. We didn't get any acute, chronic, or acute on chronic from the provider. So all we can code from the current documentation until they specify is pulmonary embolism, unspecified acuity. Now, the scenario sure sounds like it's acute. It's not documented as such. There are several risk factors present. At least two of them are overtly stated here: obese, chronic pulmonary hypertension, sedentary lifestyle, working long hours at a desk, sitting all day. So there's some risk factors in there. That doesn't necessarily mean the patient has chronic PE. Even the word anticoagulated doesn't mean much. The patient might have chronic PE and be on the same anticoagulation that they take otherwise at home for this period of this admission as well. So we only have unspecified acuity possible here. For PE, keep it in mind, acute PE means sudden blockage in pulmonary arterial blood flow. It should typically arise from a new DVT that has embolized, most commonly from the lower extremity, although upper extremity DVT is also possible to lead to PE. So don't think it's always lower extremity. That wouldn't be true for the exam. Stay away from the always and never type choices. A high D dimer doesn't rule anything particularly in here because D dimers can be elevated for a host of reasons, like infection and inflammation and other things. If you have a low suspicion of low suspicion of PE, and the D dimer is low, that there's some value there in ruling out the condition. But just because a patient has a 500 nanogram per milliliter or higher D dimer, it's highly suggestive of acute PE, but it does not define it. You may see additional value in analyzing these cases to see if there's any acute right heart strain or even acute cor pulmonale, which is not the same thing. Acute cor pulmonale implies acute right-sided heart failure rather than just strain of the heart. So you have to think carefully. So that acuity needs to be documented. Beware that massive PE or saddle PE also doesn't get you acuity, even though they're clearly acute in nature. And particularly important is massive and saddle PE doesn't capture the associated comorbidities like cardiogenic or obstructive shock, or some of the other comorbidities that typically accompany massive or saddle PEs, like a acute exacerbation of heart failure. So it's very important to be explicit as providers when we document conditions, and CDI specialists need to be ready to delineate between that which can be coded and that which cannot. And that's what CCDS likes to test. Okay, we have time for another question here. Let's take a quick look at this one. Okay, so we have a patient with a STEMI Some time back, looks like 3 weeks back, the patient underwent PCI with a stent to the LAD for this STEMI, and the documentation states, patient presents for ongoing inpatient management of STEMI-related symptoms requiring further med adjustments and close cardiac monitoring. So, Kaylee, I agree with you that this is within 4 weeks. So it still counts as a current MI if it's within that 28-day period. Very good. So based on that, Kaylee, which choice you like? A, what type of STEMI did the patient have? Since we can call it an extension of the same current STEMI, which type did the patient have? Anatomically, it was affecting the LAD. So yeah, good. Good thought, Kaylee. Switch it up to choice D. Because we can treat this, it's only been 3 weeks, we can treat this as an ongoing and current management of the prior MI until we get past a month later. Has the patient had another MI? Not yet. We hope that they don't because they're in and being managed at the hospital. If they were to have another MI, you might have a subsequent MI code as well. But in this case, it appears to just be that the existing MI from 3 weeks prior is still being treated because of the timeline. We would use I-21.29 if we didn't know the site. But because the provider documentation refers back to the original MI in essence, and the timeline allows us to go back to that, we have a better code in choice D. Yeah, no worries, Alicia. The point of these questions is the more you practice them, the more you'll pick up every little word in the stem of the question. So if you miss something on the first or second read, and I'm also talking while you're trying to perhaps pay attention to it, it's different than sitting and carefully analyzing on test day. What I appreciate here this evening is everyone has participated nicely and given some thoughts to why the questions and answers are what they are. Old MIs don't have symptoms like this patient has. They would be healed MIs for the most part that still show some sign that they were there, maybe in the way of an ECG anomaly. And for convalescent care and PT and OT related to many conditions, we may use Z codes to explain aftercare. So keep it in mind. Yeah, new codes will be revealed to you through your study if you don't commonly use them in your day-to-day work. And so that's all very valuable to know as feedback. That's what we have time for in today's webinar. We do have some more free webinars upcoming. As soon as next week, we have, as part of our comprehensive CDI apprenticeship webinar series, the chart review technique session around hematological diseases. Certainly hope to see some of you there. We have in April, on April 29th, we'll have renal diseases in the same series for the comprehensive CDI apprenticeship. And then for the CCDS exam prep webinar series next month, April 22nd, respiratory diseases, and the following month, May 20th, neurological diseases. I appreciate your comment, Michelle. Many CCDS examinees getting ready to sit down and take the exam have the same feeling you do about cardiovascular CDI work, particularly around PCS coding, DRG assignment, and some of those definitions and sub-rules regarding MIs and other entities that we discussed tonight. So thank you so much for attending. I appreciate the comment. If you're interested in any of our courses, we do have the next CCDS live online class, or course rather, beginning April 7th, and then the following month on May 5th. And we have an on-demand version of the CCDS exam prep course that is self-paced, That'll begin on April 14th. And finally, the CCDS mock exam is available anytime. You can count on a good, thorough discussion of the 100 questions if you sign up for that. So thank you, Kaylee. I had no idea. I think I know which coworker you mean. And I appreciate you mentioning that. We've had a few good success stories in the past 10 days or so. And just a thrill to see all of you here this evening. If you have any other questions for me before we sign off, I'm happy to stay on for a few more minutes and field your questions. Otherwise, that would be the end of the presentation for tonight.